Okay, so we'll get started. So today we're going to talk about the cardiac and pericardial tumors. So we'll start with this case over here. So you guys, the echocardiography on this patient showed a mass in the right atrium. You can see the arrow pointing to it here on the CT. So here is the cardiac MRI. What kind of view is that? What pulse sequence? What kind of view is this? Yeah, so this is SSF the right blood imaging 4-chamber view. And do we see the abnormality there on the MRI? Yep, so that's this area right over here. So what does that represent? Yeah, so louder so everybody can hear you. Are you next to the microphone? That is correct. That is the crista terminalis, so that is a normal structure within the right atrium. So that separates the smooth portion of the atrium from the more trabeculated portion of the atrium over here. So we don't want to mistake that for any kind of abnormality. Okay, so that is a normal structure, the crista terminalis. So over at Beth Israel, what do you guys think of this case? Yes, I can hear you. What do you think of this case? We have two CT scans here. What's the abnormality and what's the predisposing condition? Right, so there's a filling defect here within the left atrial appendage. So what do you think that represents? Right, so that's most likely to represent a thrombus. And what are the predisposing conditions? Sure, atrial fibrillation. Also, the patient has an enlarged left atrium. Also, mitral valve disease. Mitral valve disease is also a predisposing condition to thrombus within the left atrium. So thrombus within the atrium, the most common location for that is the left atrial appendage because there tends to be stasis of blood flow there. So that's a very common location for patients to develop thrombus. So let me show you guys this case also. It's kind of a companion case. So tell me what you think of this over at Beth Israel. So what makes you think that this is pseudothrombus? Yeah, so there's a straight level here between, it looks like there's contrast that's layering out dependently, and there's a straight line here suggesting that this might represent unopacified blood as opposed to a true thrombus. So what should we do? Right, so we get an immediate delay, right? So we get immediate delayed imaging here, and we will see that on the delayed imaging that we can see that the filling defect goes away, okay? So when you're dealing with these cases of what might be pseudothrombus, and this is also part of our protocol when we're doing pulmonary vein imaging prior to ablation procedures, part of the protocol is to include a set of delayed images, and it only takes a few minutes after you've given the contrast, is that any filling defect that you see there on your initial images, as the contrast gets a chance to mix around with the unopacified blood, then the whole thing opacifies. So what happens is that because of the atrial fibrillation, there's stasis of blood here at the tip of the left atrial appendage, and the contrast is denser than the blood, it's heavier than the blood, so it tends to layer out on your initial images. But if you just image a few minutes later, what happens is the contrast gets a chance to mix in, and then the filling defect goes away. So that is left atrial appendage pseudothrombus. Now, we can also it's common to develop thrombus in the right atrium, especially in patients who have central lines or catheters. So this is a patient who has a ventricular shunt, and the shunt is extending down the superior vena cava into the right atrium. So patients with central lines or any kind of catheters going into the right atrium, it's common for patients to develop clots around those lines too. So that is also a predisposing factor for developing thrombus within the atrium, okay? So, you guys over here, this patient has a history of myocardial infarction. What sequences, what views are we looking at? Speak into the mic. Right, so this is these are SSFP, so this is a 2-chamber view, and this is a 4-chamber view here, okay? And what's the abnormality in terms of wall motion that you see here? Nicely illustrated on the 2-chamber view. Yeah, so in the apex, there's actually dyskinesia. We see that it's bulging out. So if this patient had a myocardial infarct, what coronary artery do you think was involved? LAD, right, so that would be left anterior descending. Is there any other abnormality? So it looks like, we're wondering, is there a filling defect here at the apex, right? So we see these 2 nodular things here, and then on the 4-chamber view over there. So certainly in the setting of somebody who's had a myocardial infarction, this could represent thrombus in the apex of the left ventricle. What would you like to see? Yeah, so we want to see some post-contrast imaging. So here's myocardial delayed enhancement. And what are the findings here on the post-contrast images? Yeah, so there's transmural delayed enhancement here at the apex of the ventricle. And is that consistent with an LAD infarct? Yes. Yes. What about these filling defects? What do we think they are? Except that is it enhancing? It looks very bright here, doesn't it? Right? So what should we do? Is there, if you suspect that it might be thrombus, is there anything that you can do with MR, especially after you give contrast, to confirm that that is thrombus? No, we looked at those already. Inversion time? Yeah, how can we change the inversion time? What will we change it to?
You should increase it.
To what number? 600, right. So usually your myocardial delayed enhancement images are done with inversion times around 200, and at those times, sometimes the thrombus itself can be heterogeneous in signal or may even appear bright. But if you increase the inversion time to 600, right, so these are the same images, just different inversion times. So these were the inversion times used to suppress the myocardium. These were the inversion times then that were used to assess the filling defects. And so what happens at a 600 inversion time is that thrombus suppresses. So this is a good way to differentiate thrombus from tumor, from neoplasms, on post-contrast imaging. So when you increase the inversion time to 600, contrast should not, the thrombus should not enhance. Tumors may still enhance at an inversion time of 600, but the thrombus will suppress, or the signal will get dark when you're dealing with thrombus. So this is what we do to confirm that a filling defect represents thrombus versus tumor after we give contrast. All right, so here we have a 46-year-old with heart failure, and here's another case where we see that globally the wall motion is markedly decreased. And again, we have a filling defect here within the apex of the left ventricle, and another filling defect there also within the apex of the right ventricle. This also represents thrombus. This was a patient with cardiomyopathy. So in addition to infarction, which can increase your risk of thrombus formation within the ventricles, cardiomyopathy also, because of stasis of blood and the decreased wall motion, can also lead to formation of thrombus, and it's nicely confirmed here on myocardial delayed enhancement views. You can see the dark signal representing thrombus there in the right ventricle here, and then here in the left ventricle. Notice that, well, I'm not showing you the lower TI numbers, but there was no abnormal enhancement in the myocardium itself in that case. So thrombus is the most common intracavitary mass. It can be homogeneous attenuation on CT, usually low attenuation if you give contrast. You might have heterogeneous signal on MR. Sometimes it can be very low signal on gradient echo imaging. There should be no enhancement, though. When you give contrast, there should not be enhancement of thrombus, and that's how you can differentiate thrombus from tumor. So here's a post-contrast imaging. You can see the region of the infarction here, another LAD infarct, and it's a common predisposing condition for thrombus in the apex of the left ventricle. Okay? And then here on CT, we have calcification at the apex of the ventricle representing a true aneurysm. And again, that's a another predisposing factor for development of thrombus. So the dark stuff then on the CT scan represents thrombus that is formed there in the apex of that ventricle. So over at Beth Israel, if I give you the history that this patient has had an ablation procedure for left atrial arrhythmia, what do we think? Anything abnormal? Do we see anything? Well, the first thing is, do you think that's actually in the atrium? Where do you think it is? So notice that the borders here, are these obtuse or acute, these margins? Obtuse, right. So these are obtuse margins, not acute, something that is actually inside the chamber should give you acute margins. So this is actually in the wall of the left atrium. So what do you think this represents? It's not a cyst. This occurred after treatment for ablation, after the ablation procedure. So this represents hematoma, right. So this is hematoma that has occurred within the wall of the atrium after this patient's ablation procedure. Okay, and that can be a complication of this procedure for treatment of atrial fibrillation. Okay, so let's go on to this case. So you guys over here, what is the abnormality? So first of all, that first image on the left, what pulse sequence is that? This one? What color is the blood?
Black blood.
Black blood, right? So this is, it's a black blood sequence. What's our usual sequence for black blood imaging? Double inversion recovery, fast spin echo, right? And this sequence here is a bright blood image, right? Cine gradient echo here. So what is the abnormality? Yes, there's this big mass that's sitting here in the right atrium, okay? So what could this be? Well, myxoma is certainly a consideration, but the most common chamber for myxoma is what? Left atrium, right? The right atrium turns out to be the second most common chamber for myxoma. So what else? Is there anything else we might consider here? Could that be a large thrombus? Sure, it might be a large thrombus, yeah, possible. Metastasis. So let me show you metastasis from what? Breast cancer? Lung cancer, breast. Well, let me show you another interesting image on the same patient. So, right, so this is a renal cancer. So this patient has a large renal tumor here that is invading what structure? The inferior vena cava, right. So when we have a large filling defect like this in the right atrium, the first thing to consider, is this a mass growing up the inferior vena cava into the right atrium? And the most common tumor to do that is renal cell carcinoma. Okay? So that can invade the IVC and grow up into the right atrium, which was the case here. Now this is kind of a companion case. So for you guys here, again, we have a mass here in the right atrium. But what is the diagnosis for this patient?
Liver.
So this patient has a tumor in the liver, right? So here we have hepatocellular carcinoma that's invading the portal vein and extending into IVC, right? So this is the second most common tumor that can grow up the inferior vena cava into the right atrium. The first most common is renal cell cancer. The second most common is hepatocellular cancer. It can also occur with adrenal cancer, and there are reports of this also occurring with ovarian cancer as the tumor grows into the ovarian vein and then up the inferior vena cava. Okay, but the most common tumor to do this is renal, and the second most common hepatocellular carcinoma. All right. So at Beth Israel, what do we think of this case? So we have a lung nodule here in the periphery, and we have this filling defect in the left atrium. So what do we think that filling defect in the left atrium is? What do we think? So what do we think the tumor is? What's the primary tumor? So a lung cancer, and how does lung cancer get into the left atrium? Through what structure? What connects the lung to the left atrium? Yeah, the pulmonary vein. So this is a lung cancer that's invading the pulmonary vein directly into the left atrium. And here's another focus of tumor. So lung cancer can invade the left atrium, either growing around the pulmonary veins or directly through the pulmonary veins. So that's another consideration for a left atrial tumor. On echocardiography, they will see this and then diagnose the left atrial mass. Obviously, they won't see the lung cancer. So you may be the first one on your imaging study to diagnose that this is lung cancer that is invading into the left atrium rather than a primary tumor of the atrium. This is an example of another metastatic lesion. I think this patient had Ewing's carcinoma. So this is another metastatic lesion here that enhances after contrast. So mets to the heart are more common than primary tumors that actually occur within the heart. So that's the point here, is that secondary neoplasms are 40 times more common than primary neoplasms. It could be lung cancer, mediastinal tumors by direct extension, renal, adrenal, liver, all those can grow up the inferior vena cava, and then mets can go anywhere in the heart, again from lung cancer, breast cancer, common tumors. Much more common than primary tumors. Okay? All right, so for you guys over here, let me show you this case. It's one of the few times where you'll actually see a head CT scan in my lectures, but there it is. So this patient had presented with a hemorrhagic lesion in the brain, and so there's a lot of edema around it. The thinking was that this might represent a metastatic tumor, so they were looking for a primary source. They did a CT scan of the entire body, and those are some representative images there going through the chest and the heart. What do we think? Do we see anything there that we want to discuss? So in the left atrium, right, what do we see here in the left atrium? There's this kind of subtle filling defect here within the left atrium, right? So what do we think that might be, and how does that explain this? So it could be a left atrial myxoma. How does it explain the hemorrhagic lesions in the brain? Yeah, so myxomas are tumors that are very friable. Pieces of it can break off, and if it's in the left atrium, you get systemic emboli. So this is a hemorrhagic infarct then, we suspect, from a piece of that myxoma that broke off. So what should we do now? What imaging study can we do in radiology to take a look at that tumor? What should we do? In radiology, we're not gonna send them to echo, not yet.
MR.
So we want to do MR. So what sequence, what view would you like to see? For chamber view. What sequence would you like to see? You'd like to see bright blood imaging sequence. Now, in your mind, imagine what that's going to show, right? What do you think it's going to show? In left atrium, what is that filling defect going to be doing? Well, it's the bright blood image. It's not contrast. Yeah, it's going to be mobile, right? So it's going to be moving. Actually, you get a sense of it here, that it seems to be maybe it's going to be mobile as it extends across the mitral valve, right? So let's take a look at that. Here it is. Here is our 4-chamber bright blood imaging sequence. Are you impressed by the tumor?
No.
What happened? Where did it go?
Popped off.
The tumor, looks like the tumor disappeared, right? Why don't we see the tumor? Why don't we see the tumor? Is there? So maybe the signal, maybe it's isointense to the blood pool in terms of the signal on this imaging sequence. So what should we do? Well, remember when we talked about imaging valves, right? That the sequence that we use for imaging valves is SSFP, steady state free precession. But if you want a bright blood cine imaging sequence that can show you turbulence very nicely, what sequence would you use? No, spoiled grass. So a spoiled grass sequence, which is this, And those images are not as pretty as steady-state free precession, but they do bring out turbulence much better. So where you have a mass here, because of the turbulent blood flow around it, it shows up very nicely on this imaging sequence. Okay, so so this is also available to you if you want to look for turbulence, or for some reason the tumor that you are looking at is iso-intense to the blood pool on your imaging sequence. So that's a non-balanced, or GE calls it fascinating, but it's a spoiled grass. It's a cardiac gated spoiled grass technique, which shows you that tumor very nicely. Okay, but of course we can also do dark blood imaging, which shows us the tumor quite nicely. Here it is with fat set. There's the tumor, no problem. And then after contrast, we can see that there is some enhancement here within the tumor. So we can't see this tumor here. So this was indeed a left atrial myxoma. Now, the features of myxoma, there are two typical features. This is a cardiac gated, what kind of study is that? CT, right, it's actually a MIP, which is why we've thickened the image here, which is why it looks a little bit different, okay? There are two imaging features for myxoma that you want to see that makes you suggest myxoma. So what are those two features? Attached to the interatrial septum, right. We want it attached to the interatrial septum, and the second feature that we want is what? Mobile, and it prolapses through the mitral valve. You want to look for those two features. If you have those two features, then the first thing on your list will be left atrial myxoma, if you see something like that. There is one other thing that might mimic this, and that could be a clot, actually, that's stuck in a patent foramen ovale. In a patient who's having pulmonary embolism, who has clots stuck in the patent foramen ovale. But there you usually can actually see it extending across the interatrial septum, all right? So that might be your only differential if you see something like that. So cardiac myxoma is a mesenchymal tumor, usually pedunculated, as we've said. It's friable, so systemic emboli, patients can present with systemic emboli from myxoma. The most common chamber is the left atrium, second most common right atrium, then you have the ventricles. You can have obstructive symptoms from obstruction of the mitral valve, constitutional systems, and of course systemic emboli. Most are solitary. The trivia question here is Carney complex. There, that is associated with myxoma, spotty skin pigmentation, and endocrine overactivity. The key there is that the myxomas tend to be multicentric and they have a high recurrence rate when they're associated with Carney complex. So, as we said, commonly attached to the fossa ovalis, or the interatrial septum, and crosses the mitral valve. So, obstruction of the mitral valve can cause pulmonary venous hypertension, intermittent pulmonary edema, and then systemic emboli. This can mimic mitral stenosis because of the obstruction of the mitral valve. So, on the plain film, in most cases, when you have pulmonary venous hypertension and some enlargement of the left atrium, most of those cases are going to be rheumatic heart disease causing mitral stenosis. But the other thing in that differential, the other 1%, can be left atrial myxoma. So left atrial myxoma from obstruction of the mitral valve can mimic mitral stenosis clinically and radiographically. And then it can have various types of signal on MR depending on how much blood there is within the tumor. You can have heterogeneous enhancement. Sometimes it might even be dark on gradient echo imaging. It just depends on how much blood there is within that tumor. Okay? And then here you have a big left atrium, and you can see how when the tumor gets big enough, it might also obstruct pulmonary venous return in addition to obstructing the flow through the mitral valve. So here's a patient who has a large right atrial tumor. Again, as we've discussed, your first thought if a patient has a large right atrial tumor should be what? So, right, metastatic tumor growing up the inferior vena cava. This happened to be a myxoma. There it's enhancing after contrast, so these can also occur in the right atrium. It's the second most common site. It can cause tricuspid regurg by damaging the tricuspid valve, and if the foramen ovale is patent, sometimes these patients can also develop right to left shunting and paradoxical emboli because of the increased pressures there within the right atrium caused by the tumor. Okay? So the right atrium is the second most common site, so this can also be in your differential for a right atrial mass. All right, so over at Beth Israel, what do we think of this case? Where's the filling defect? Yeah, so what is this guy here? What is this guy? Yeah, so here we have the small filling defect that's attached to the aortic valve. What kind of view is this? Yeah, it's an LVOT view, left atrium, left ventricle aortic valve. So you have a filling defect here attached to the aortic valve. So what's the differential diagnosis? What could this be? So papillary fibroelastoma is the most common neoplasm that might attach like that to the aortic valve. But more common than papillary fibroelastoma would be what? Sure, vegetation from endocarditis or a blood clot. Okay, so that would be more common. So it would be important to know, does this patient have any findings that are associated with bacterial endocarditis? And this patient, was asymptomatic for that, and this indeed was a papillary fibroelastoma. So we can see it here also on this view going right through the aortic valve, this papillary lesion that's kind of attached to the aortic valve, and that is the most common location for these unusual tumors. So here are volume rendered views showing you this papillary fibroelastoma attached to the aortic valve. But as I've said, if you're just looking at the imaging, the first thing on your differential might be endocarditis or blood clot. And then if the patient is asymptomatic, then maybe papillary fibroelastoma. So this is the second most common benign cardiac neoplasm. The most common is myxoma, but it accounts for 75% of valvular tumors. These are usually small. Usually patients are asymptomatic. Usually it's discovered incidentally, especially on echocardiography, and there's usually no associated valvular dysfunction. Okay, so filling defect on the aortic valve. Most patients are asymptomatic with this lesion, papillary fibroelastoma. Okay, so St. Barnabas, are you there? Okay, so here we have a coronal image, and I will give you the history. We have a cardiac tumor in a newborn. What will this be? So rhabdomyoma is the most common cardiac tumor in a newborn, and what is that associated with? Correct, that is associated with tuberous sclerosis. So rhabdomyomas are really myocardial hamartomas. So these are associated with tuberous sclerosis. The good news is that when these occur in infancy, they tend to regress on their own. They make up 90% of cardiac tumors in infants, usually very young, and they tend to regress spontaneously. So they can be multifocal, as in this pathologic example there. So it can cause arrhythmias. It can give you this thickening of the myocardium. It can be iso-intense, the myocardium on T1, and slightly hyperintense on T2 weighted imaging. So these occur within the myocardium. Now, this kind of a companion case to that. These are two different patients with the same disease, and the disease is characterized by seizures, mental retardation, and skin lesions. So what is the disease? St. Barnabas? Yeah, again, it's tuberous sclerosis, right. So what are these lesions? Notice? No, it's not a fibroma. Look at the attenuation. The attenuation is what? The attenuation is fatty attenuation, right? So if we see that in the lung, if we see a fatty attenuation lesion in the lung, what do we call it? Hamartoma, right. So patients with, even adult patients with tuberous sclerosis can develop these hamartomatous-like lesions within the myocardium, and that will have some fatty attenuation associated with that. And in one study, 64% of these adult patients with tuberous sclerosis had these fatty lesions in the myocardium. So this can be associated with tuberous sclerosis. Okay, so you guys over here, what's abnormal on this CT scan? We have pre and post contrast CT. What is abnormal? Calcification, right. So we have this thickening of the left ventricular wall here with calcification here in the wall of the ventricle, okay? Now let me show you some more imaging. This is a T2 weighted image, and then here we have bright blood and post-contrast. First, describe what we see. So there's marked enhancement, right, after contrast, there's marked enhancement of the lesion, okay? And on the T2 weighted image, what is the signal intensity of the lesion? It's hypointense. It's very low in signal. Most tumors are bright on T2 weighted imaging, but this tumor is dark. So what is this tumor? Fibroma, right. So dark on T2 is a characteristic of lesions that have a high fibrous content. So you'll see this, when you're doing pelvic MRI, looking at leiomyomas in the uterus, they will also be dark on T2 weighted imaging. So tumors with a high fibrous content are dark on T2. This is a fibroma within the heart, and that you can guess that based on the imaging characteristics. Okay, so hypointense on T1, especially on T2, these have marked contrast and enhancement when we give contrast. So that's the clue that you're dealing with a fibroma. So these can be congenital. It's the second most common cardiac neoplasm in children, but it's the most common to be resected. Remember, the most common is the rhabdomyoma, which tends to regress on its own. Trivia question, it's associated with Gorlin syndrome or basal cell nevus syndrome, and it could cause various symptoms there, sudden death from a compression of the conduction system. But it might have that characteristic imaging feature of being very dark on T2 weighted imaging, and about 25% of fibromas are also associated with calcification. So that can be another clue that you're dealing with a fibroma. And we talked about the dark signal on T2. Okay, so over at Beth Israel, here we have another patient with a cardiac mass, T1 and T2 weighted imaging. What do we notice on the T2 weighted imaging about this lesion? It's very bright on T2 weighted imaging. Right, now tumors can be bright, but this thing is really bright on T2 weighted imaging. So here's a CT after contrast, and then here's 5-minute delayed CT, the same location. So what happens to the tumor 5 minutes after contrast? Right, it becomes isodense to the blood pool. And then here, when you look at the PET scan, do you think this is a malignant or a benign tumor? Yeah, it looks benign because there's not much here in the way of metabolic activity. So what tumor do you think this is? Yes, if you put that in the liver, that would be a hemangioma. And this is a hemangioma. It becomes isodense to the blood pool there on your delayed imaging. So hemangiomas are very bright on T2 weighted imaging. Okay? They will enhance after contrast, and just like in the liver, they can become isodense to the blood pool, as in this particular case. So that was a cardiac hemangioma. Sometimes they might have calcifications, like phleboids within them. So that you might also see sometimes with these hemangiomas. Okay? All right. So over at St. Barnabas, here we have a person who has a mass in the right atrium, and we can see it there on the bright blood imaging, right? Notice how it's kind of changing in shape through the cardiac cycle, and then we will look at some more sequences on this. So here's some dark blood images here. So what can you tell us about this lesion? St. Barnabas? So on this dark blood sequence, the signal intensity is what? It is quite high, right? So it's the same signal intensity as what else on the image? Fat, right. It's the same signal intensity as fat. So what are you thinking about? Lipoma. So what can you do to prove it's a lipoma? Fat suppression, which is what's done here. So here, without fat suppression, it's very bright, just like the fat. And then when you use fat suppression, you can see that you can suppress the signal, and that confirms that this is a fatty lesion. So this is a lipoma. These can also occur here, especially along the insertion of the inferior vena cava or along the right atrial wall. Here it is on CT, very easy to tell that that's fatty attenuation. and that represents a lipoma there within the wall of the right atrium. So the right atrium near the atrial septum, it's a common site near the IVC. So those are common sites to get these lipomas. Fatty attenuation on CT, bright on T1, and when you use fat saturation, you can make it go dark, okay, on MRI. So there's another example of a cardiac lipoma. This one here is kind of in the wall of the left ventricle. With fat saturation, you can make it very dark, and it's got fatty attenuation there on the CT. And then another feature of these tumors is that they are very soft and pliable, which is why you can see that throughout the cardiac cycle, you see how it's very compressible. It kind of changes shape very easily throughout the cardiac cycle, okay? All right, so you guys over here, this patient has a history of hypertension, and we have an MR that shows this mass. There you can see it there along the right atrium. What do we think this is? So what tumor, what cardiac tumor might be associated with hypertension? Paraganglioma, right. So, or an extraadrenal pheochromocytoma, which is a paraganglioma. So that should be what you're thinking about in this case. And the other thing about paragangliomas is that they are very vascular tumors. So here you can see how that tumor vascularity, the marked vascularity actually fed, in this case, by branches from the right coronary artery. So paragangliomas are very vascular tumors. So they do enhance markedly then with contrast. So these can arise from chromatin cells in the heart, can arise commonly from the roof of the left atrium. Most reported cases are catecholamine-producing tumors, like pheochromocytomas. A certain percentage can have paragangliomas elsewhere also. So these tumors do enhance. So after you give contrast, you can see marked enhancement within these tumors. They can involve the left atrium. They can be seen along the roof of the left atrium. They can also be seen around the roof of the aorta. You have to be careful, though, about hypertensive crisis with these lesions. And as you increase the T2 weighting, paragangliomas, that's another class of tumor that can be very bright on T2 weighted imaging. Okay? And the way you can look for these is with nuclear medicine, MIBG. So these tumors will light up on an MIBG study. Okay, so over at St. Barnabas, this patient has arrhythmia. What do we think is going on in this patient? Right, there's marked thickening of the interatrial septum, and you can see it here on this short axis view. Here's the left atrium, here's the right atrium. That is the interatrial septum. Here's a four-chamber view here, marked thickening. And what else do you have to say about it? Yeah, so it is fatty in attenuation. And notice also here this particular shape, right? So this is called a dumbbell shape. It kind of drops out in the region of the fossa ovalis. So these are characteristic features of this lesion. What is this? What is this? What do we call this? Right, so this is lipomatous hypertrophy of the interatrial septum, okay? So it's a non-neoplastic accumulation of fat cells, usually brown fat. It's associated with aging and obesity, usually asymptomatic, but it can cause arrhythmias. Why can this cause arrhythmias? What lives here? SA node, right. So it can infiltrate around the SA node. It might cause arrhythmias. So we look for fatty thickening of the interatrial septum. And so if we have that thickening and also that kind of dumbbell appearance where it kind of drops out at the region of the fossa ovalis, that's another characteristic feature of this tumor, okay? And on MRI, so here fatty attenuation on CT, fatty signal on MR, and you can make it drop out, of course, when you do fat suppression. Okay, you guys over here, the history is gastric cancer. And this patient has a lesion that lights up in the interatrial septum here on the PET scan. Is this metastatic disease? No. Why not? What is it? So, and right, again, it's another example of lipomatous hypertrophy of the interatrial septum, but this is brown fat, and brown fat is metabolically active on PET. So this can give you a false positive PET finding, right? So again, it's important to recognize the attenuation of that, the location, the appearance, that this is lipomatous hypertrophy of the interatrial septum, and it can give you false positive PET scans, okay? So, another example, nice false positive PET scan. Okay, over at St. Barnabas. Now, of course, your first thought, if you see something like that, like this, would be a metastatic lesion. But if I tell you that this is a primary cardiac tumor, what primary cardiac tumor would you suggest here? Angiosarcoma. So what are the features that make you think angiosarcoma? Yeah, it's an invasive tumor, so it looks malignant, just the looks of it, the way it's kind of invading the the chambers there, okay? What about the location? Yeah, it's on the right side. So it's a right-sided malignant cardiac tumor. So angiosarcomas are the most common primary cardiac malignant neoplasm, but they tend to be right-sided tumors. Okay, so that is a feature associated with angiosarcoma. So big ugly tumor arising on the right side of the heart. So there, if we're thinking primary cardiac tumor, we think angiosarcoma. Now, this is the second most common primary cardiac neoplasm. The most common primary cardiac neoplasm, of course, is myxoma. There are different sarcomas that can occur. The angiosarcomas are the ones that are the most common, and they tend to involve the right-sided chambers. The other sarcomas seem to have a propensity for left-sided chambers. Okay? Features that suggest malignancy, these are kind of obvious. Tumor involves more than one chamber, wide point of attachment to the heart. If there's a hemorrhagic pericardial effusion, intracavitary involvement, if it extends to surrounding structures, and of course if there is metastatic disease. So the angiosarcomas usually occur around the right atrium. Other sarcomas more common on the left side. It can cause tamponade or obstruction. Many will have metastatic disease at the time of presentation, especially mets to the lung. And angiosarcoma, big, ugly, right-sided cardiac neoplasm. Here's an example of a leiomyosarcoma, and the other types of sarcomas more often occur on the left side. This one next to the left atrium. Okay, this is a very rare and unusual tumor in this case. So you guys over here, any guess as to what this might be? Yeah, this is an osteosarcoma, right? And how do you know? Well, because there's osteoid matrix in this tumor. You see that in the bone, you have no problem calling that an osteosarcoma. These are rare, but they can also occur in the heart. Don't ask me how, but that's an osteosarcoma that has occurred there within the heart. It's not metastatic disease. That's actually primary tumor in the heart. Okay, again, over here, if I tell you this patient is HIV positive, and we're looking at the imaging here on this patient, what are we thinking about here? What could this be? What? So Kaposi sarcoma certainly is a consideration, right? So Kaposi's can give you metastatic disease to the heart. So this looks like there's a big ugly tumor growing around the heart, infiltrating the heart, also involving the pericardium. There's a big pericardial effusion. So Kaposi sarcoma, yes, could be. Lymphoma, right. This was cardiac lymphoma, okay? So if you have a big extensive tumor like this involving the heart, kind of infiltrating all compartments, lymphoma is a very infiltrative tumor, and especially in patients who are HIV positive, we need to consider lymphoma. So these are usually non-Hodgkin's lymphoma, and this is associated with AIDS and HIV, these cardiac lymphomas. You can have a heterogeneous mass involving the right atrium or right ventricle, really can be anywhere around the heart, and pericardial effusions, invasion of the pericardium, all of those are common with cardiac lymphomas. Okay? So we discussed the benign tumors here, we've discussed the malignant tumors. Remember, the most common primary cardiac malignancy is sarcoma. Angiosarcoma, the most common of those, usually right-sided lymphoma. Think of that especially in a patient who's HIV positive. All right, so over at Beth Israel, what's abnormal on this chest x-ray? Yes, there is a mass, correct, in the right cardiophrenic angle. So we'll take a look at that on CT. Here it is. What do you think that is? Right, so what are the features that make you think pericardial cyst? Yes. Yeah, it's in the right cardiophrenic angle. They can occur in either cardiophrenic angle, but it is fluid and attenuation, very well circumscribed. There's no nodularity, no mass associated with that. So that is a pericardial cyst. So in terms of pericardial tumors, these are pericardial tumors that might occur. The pericardial cyst, these arise from the pericardium. The cysts are in contact with the pericardium, but they do not communicate with the pericardium. So it's like having a loculated pericardial collection there. Common in the cardiophrenic angle, right greater than left, very smooth-walled, well-circumscribed, fluid attenuation, and there's no enhancement, very thin wall with these things. Okay? So here's examples on MR. They can be higher than fluid signal on T1 weighted imaging because of proteinaceous contents. No enhancement after gadolinium, very bright on T2 weighted imaging like cysts anywhere else. Now, we can have secondary neoplasms affecting the pericardium, metastatic disease, lung cancer, breast cancer, melanoma, an example of breast cancer here with metastases to the pericardium. Teratomas can also occur, but these tend to affect very young patients, infants and children. This is a 1-month-old here with a teratoma. So in an infant with a pericardial tumor, you might suggest teratoma. These can contain calcifications also, just like teratomas anywhere else. And over here, you guys, if I tell you that this is a primary pericardial neoplasm, what pericardial neoplasm would this be? Besides metastatic disease, of course, metastatic disease would be, well, that's secondary, but if it's a primary pericardial neoplasm, what would you pick? Mesothelioma, right. So mesotheliomas, of course, they arise in the pleural space. They can also arise from the peritoneum, but they can also arise from the pericardium. So this is a large mesothelioma there arising in the pericardium. So these arise from the mesothelial cells of the pericardium, and it's controversial whether or not there's an incidence or there's any relationship of this to asbestos exposure. These are quite rare, so it's very hard to figure that out. But there's a regular thickening of the pericardium, pericardial effusion, and masses, of course, along the pericardium with mesothelioma. So very diffuse and irregular pericardial thickening with masses and with pericardial effusion. That's what we see with pericardial mesothelioma. So what are the things that you need to remember? Don't forget about the crista terminalis. That's a normal structure there within the right atrium at the border of the smooth-walled portion of the atrium with the trabeculated portion, so you don't want to mistake that for a tumor. In terms of cardiac tumors, the order of your thinking, think thrombus first, secondary neoplasms next, and then primary cardiac tumors last, because these are quite rare when compared to the first two. Thrombus, that is the most common intracavitary mass, very common in the apex of the left ventricle, associated with infarct, especially in the distribution of the left anterior descending coronary artery. You can have lung cancers that invade the left atrium, and they can invade through the pulmonary veins, and that's still more common than primary neoplasms of the left atrium. Myxoma. This is the most common primary cardiac neoplasm. The imaging features attached to the fossa ovalis and prolapses through the mitral valve. Can mimic mitral stenosis clinically and radiographically. and the trivia question, Carney complex associated with myxoma. Lipomatous hypertrophy of the interatrial septum, fatty thickening of the interatrial septum, dumbbell shape, it drops out in the region of the fossa ovalis, false positive PET scan because of the brown fat. Papillary fibroelastoma, papillary lesion attached to the aortic valve, but the first things on your differential whenever you see something like that would be endocarditis or clot. Fibroma, dark on T2 weighted imaging. Most neoplasms are bright, but this is dark, and it enhances markedly after you give contrast. Cardiac sarcomas, the angiosarcoma is the most common, usually right-sided tumor. So right-sided primary cardiac neoplasm is angiosarcoma. Okay? Pericardial cyst, fluid attenuation in the cardiophrenic angles. And that is our discussion of cardiac tumors.